Right. Unusually, I'm going to start with an apology that we're starting this meeting late. That is because the chair stupidly took an item this morning that should have been this afternoon, so we are running a little late. So I apologise to people here today who have been kept waiting. Entirely my fault. However, can I also, with an apology, say that we have a very full agenda, and despite having taken one of the items that was for this afternoon this morning, there's an awful lot of other things this afternoon. So we will have to finish the meeting on time. If there is time for questions from the public, and I know we've got 2 or 3 questions already notified to us, we'll take them, and if not, we'll respond to those questions in writing. But I'll do my best, with the board's help, to have some time for the questions if we possibly can. So that's a sort of general apology. We have no apologies of absence, but I do particularly want to welcome Rosie Bennyworth, our Chief Inspector of Primary Medical Services and Integrated Care, to her first board meeting, and also Mark Sutton, who, if you look at the name tag, says is the Chief Digital Officer, but actually he isn't until next week. But you're very good you're here today, Mark, and we look forward to working with you in the future. And I also want to welcome Ian Henderson, sitting there. Ian chairs the CQC Carers Equality Network and is our Equality Network representative at the board today. So that's that. Is there any declaration of interest anybody on the board needs to make? Very good. That takes us to the minutes of the 20th of February meeting. Are they a true and accurate record of all we discussed? In that case, I'll take them as approved. There was one item on the action log which has been completed. Is there anything else arising anybody wanted to raise? In which case, Ian, we go on to the executive report, please.
Thanks, Peter. Thank you, Peter. The executive report covers off a number of issues. I think it's fair to say there's good performance overall. We talked last month about increasing month-on-month performance in terms of particularly around timeliness of report writing, which is one of those headline measures that people set great store by, and I think talks to what we do as part of our core business. I think what's slightly hidden in some of the numbers, I think, is some really good work on backlogs. I think what we've struggled with in previous months is performance which has been slightly held back by having big backlogs, and the backlogs are coming down as well, which I think is a really positive sign, and it's a great testament to the hard work that a number of my colleagues have done. I think I'd also like to just talk about the effectiveness of going back to the same locations quickly. In the performance report, we talk about going back to adult social care providers, particularly those who require improvement and are inadequate. And I want to just give assurance that we are looking at that from a much more risk-based approach. So those that are most risky are more likely to have people go back and talk to them. Can I just invite Debbie just to touch briefly on the work they're doing in adult social care in that space, because I think it is quite an important point that we don't often talk about. Debbie.
Yeah, so thank you for that, Ian. I think it's really important to look at the data differently as well, because at this moment in time, the ratings for inadequate and requires improvement are actually lumped together. But if you were to separate the data, year to date, we have achieved 84% of return inspections within KPI of 90%. And for January, we've actually exceeded the KPI of 93% returns to inadequate locations, which obviously I hope will assure people that we are ensuring that those services that are most at risk are receiving the attention that they require. In relation to requires improvement, we year to date, if you split it down, it's 56% of those services that we return to. However, from the data, when you start to unpick it, we can actually demonstrate that those services where we have returned to out of KPI out of the key performance indicator, 48% of them were actually completed within 4 to 6 weeks. And of those services, the majority are actually improved their rating to good, which again, hopefully demonstrates that the risk assessment model that we've put in place in adult social care is actually demonstrating that we are returning to those services at the right time, depending on the risks and the information that we are receiving. So I think that our insight information and our assessment of risk at each location is accurate. I expect there to be huge improvements as we move through the next quarter, and I'm assured through the information that I have seen that all those services that we haven't quite got to yet are in the process of being inspected and will be. This is inadequate and requires improvement, and will be by the end of the 31st of March.
Thanks, Debbie. Can we move on to Ted? Sorry.
So, sorry. Do we want to take the? Do you want to go through the chief inspectors and then do the performance?
Yes.
Yeah. Okay. Fine. All right. Sorry. Carry on, Ted. Beg your pardon.
Okay, as we get to the end of the financial year, we remain on track to complete our programme of inspections. You may remember we'd set the target of getting to the end of all the NHS trust inspections using the next phase methodology by June of this year, and we remain on track to deliver that. And as we're going forward, we're assessing the next phase methodology, particularly the well-led inspections, to understand how we can continually drive improvement in that process. And the board is well aware that well-led is very central to our plans for inspections going forward. In terms of report timeliness, which the board is aware that we are below KPI on, we maintain the sustained performance that the improved performance that we developed towards the end of last year, but we are still below KPI. We've hit the target we set ourselves of 50% by the end of the year, over 50% by the end of the year. But I think without further changes to our report writing process, we will not be able to get up to the KPI, and that work is well underway. The work will be, we're launching from the 1st of April a new approach to writing reports, which is very much akin to what ASC has already developed in terms of using more standardised statements to define the reports, to make the reports easier for the inspectors to write, but also, I think, to help drive consistency in the reports, which is another thing we're focused on. So as we go into the new financial year, the reports will be getting more consistent in the language they use, and I hope shorter, and we'll be able to produce them within the KPI. So I'm very hopeful we'll drive further improvement in that going forward.
If we move across to Malta.
Great, thank you, Ian. So first of all, from me, an update on our preparatory work for the EU's exit. When this report was written, the exit date was still the 29th of March. It remains the 29th of March, subject to parliamentary process and potential legislation. Like all other organisations, we've worked hard to ensure that we are prepared for the exit day, both internally as an organisation and in terms of our regulatory role. We've tested our own readiness in terms of our staff, our processes, our legislation, our data and our contracts, and I've identified low risk for all of those issues, so are confident that we're in a good place. I'm also very pleased to say that we've, I think, supported our own staff who are EU members, who are family and friends from the EU in that process well. As importantly, we've also looked at what this means for our role as the independent regulator for quality in health and social care, and our first priority is always, also during this time, will remain to people who use services and to ensure that high quality safe care is being delivered. So we will continue to monitor and inspect services, and we will make sure that any issues or concerns that are arising during this time will be raised and escalated as appropriately. As part of that, we'll be working very closely with the Department of Health, who's coordinating the wider efforts around this, and we will respond proportionately and also flexibly to any issues that might arise. So we're in a good place as far as it goes. Are there any questions on that before we move on? No? Okay. The only other thing that I wanted to mention, there is a number of parliamentary activities I wanted you to be aware of. I'm not going through the detail, but the evidence we gave to the CARC review, the work on autism by the All Parliamentary Group, and the way we're now starting to brief the independent group as the members of Parliament that has been newly established. Chris, do you want to summarise on the publications?
Certainly. So 3 main publications to bring the board's bring to the board's attention. The first one is a comprehensive review of independent ambulances. This is the first time this sector has been formally regulated, and we've shown both the variation with good practice and areas of concern. I'm pleased we've had a good response from both the providers of these services and the commissioners of those services. It's very clear that this is an important sector for health and care, and a growing sector in terms of people moving between hospital and home. So we've had a good response. Our intention is to continue to work with the sector to highlight the areas of concern to us, particularly around maintenance management, but also to show what is possible. We've seen a number of organisations that we initially rated as requires improvement or inadequate, moving to good. So we should talk about those as well. The second review that's happened is our following review from Learning from Deaths. You may remember the conversation we had with a number of parties about 2 years ago. What we wanted to do with this report is to go back and see what lessons have been learned since our first review, and particularly to how the organisations adapted its culture, how organisations are taking on board the cultural changes that were necessary in order to make sure that organisations genuinely learn from the issues that happen. Please say there's been a good response to that and good support, but there's still some issues. We're very clear of some of the poor culture in some organisations that are not yet capable of learning from the mistakes that are made, and we obviously follow up with those individual organisations. But this was an opportunity to sort of say what has happened since, and indeed what still needs to happen, not just at local level, but at national level as well. The final report, independent doctor's report, due out tomorrow. Similar to the independent ambulance report, it's the first time this sector has been regulated in this way. And again, we see a variation from very good performance in some parts of this sector to very poor and worrying performance. Obviously, we've taken action in terms of the individual organisations, but this is trying to work with the sector and with commissioners and with individuals so that they understand the implications of poor care, and so that will be launched tomorrow.
We've got the performance report we want to come back to. I don't know if you want to say anything by way of introduction, or we take it as read and just take questions.
Take it as read.
Yep, perfect, good. Questions? Lewis, you look as if you want to ask one, and then Liz.
Thank you. I just want to ask about the adult social care inspection. So first of all, congratulations on predicting the question that you were going to be asked about. It was because the figures look, on the face of it, the figures presented here, which are different from the ones you've just said, Debbie, are just a little bit concerning, because this is about inspecting care homes that have been previously had a poor rating, and the figure we've got is that we're in the charts that we've been given is that we're at 64% overall, which and in the case of the requires improvement and inadequate care homes, the figure is I think it's something like 62%, whereas the target is 90%. So that's very substantially below. Now we're giving us some different figures there, which you know, it's kind of hard to assimilate a different set of figures there. Maybe you could just clarify that, because in the graph that you've presented, the histogram which shows the month by month rates of inspection, I thought you were saying something very positive about January, but when you look at the months this year, January, February, March, the rate is it's a little bit higher than earlier in the year, but it's not very much higher overall, which doesn't give the impression of a very, very big rise. And in fact, in March, the most recent figures, the figures are just at the same level as they were at the beginning of last year. So it doesn't give a picture of overall improvement. And that's not to say that what you said isn't right, but it's not consistent with what you've presented to us. And then part of that is that all the figures are based on this, what I must say is a phenomenal performance by social care inspectors to have got around 9,800 locations in the current year. So that is a tremendous performance. But when you look at the re-inspections according to previous ratings, that's about 7,500. So that must leave more than 2,000 that are somewhere else. Now, I'm guessing that they are mainly newly registered care homes. And if we're doing well on the re-inspections, but overall the figure is not that good, then we must be doing quite badly on the new inspections. And now that concerns me. So these are newly registered care homes where our rate of inspection is really must be quite low. It must be below 50%. So two questions. One is, can you just clarify the inconsistency, positive though it is, with what you just said, and then what's happening to the new care homes? Sorry, that was a slightly statistical sort of thing. But on the other hand, this is a really important issue because it's about inspecting potentially the most vulnerable care homes that we have.
Absolutely, and I take your points on board, and I have introduced some new statistics, and I felt it was important to introduce those new statistics because the way that the information is reported in the performance report at the moment is very much putting together the requires improvement and inadequate locations. Therefore, I've spoken to the performance and evaluation team, and going forward, the report will read differently. It will be split up into the areas that I've just discussed. So when I broken the data down to have a look at your very concerns, because I too was concerned, when I look at the inadequate locations year to date, if you just concentrate on inadequate, 84% of those were completed within the KPI of 90%. And for January, that's actually increased to 93%. And for February, the early indications are it's going to be around 91%. So those are that's the sorts of information that you'll see going forward. So inadequate services, I think that we are tackling those services in the right way. For the small percentage where we haven't achieved, I've looked at the data. 5 services in January where we were out of the KPI for inadequate locations, and out of those 5, 2 of them were in enforcement, 1 of them was a registration issue, 1 of them we had to change the date because there was an outbreak of infection, and 1 of them was an error on behalf of the scheduling. That was an error. So when you actually break it down, I am more assured. The requires improvement locations are more problematic, and we haven't necessarily been getting back to those services within the required timescales. So we've looked at developing some principles around the requires improvement, and we've discussed before at the board the scale of requires improvement. So you can have an overall rated location of requires improvement that actually has 2 good key questions, 3 key questions requires improvement, and no breaches. And then you can have a service that's rated as requires improvement with 5 key questions requires improvement, breaches, and warning notices where we're taking enforcement action to drive that improvement. Those are the services that we've been concentrating on for a return to inspection, but also at the back of our mind monitoring the other services so that there is some key information of concern that's coming in from intelligent sources, then we absolutely escalate and bring those forward, and we do bring a number of inspections forward. The data is also showing that the majority are actually completed within that 4 to 6 week period of the KPI. So again, I think it demonstrates that we are using our risk assessment model in the right way and returning to those services. But going forward, we've developed 3 of the heads of inspection who are actually looking at the scheduling of inspections for Q1, Q2 of the new financial year. A presentation yesterday, we had a presentation at our SLT, and I am confident that we have now got a clear plan in place that is supporting those areas of the country, for example, Central Region, which is an outlier at the moment because the risk profile has increased. So Central Region is now receiving support from North, London and South, and also the additional support of some colleagues from PMS as second inspectors to help us get through that backlog. And I'm confident by the 31st of March, when I checked some of the system issues yesterday, that those services that fall into that category of requires improvement where we've not met the KPI are actually, the inspection has taken place and we're about to publish the report, or the inspection has taken place and the rating has improved to good. So I've personally checked some of that information out, and that's why I'm more assured, Lewis.
Yeah,
Can I come back for 1 second?
New registration.
Ted, did you want to add to that before Lewis comes back?
I just wanted just a bit of context. I mean, Debbie's describing the situation in ASC, but I think that the discussion we're having does highlight some of the problems we see with our current operating model in terms of inspections based on the most recent rating and then time since the last inspection. And that certainly in hospitals we find that drives our schedule very, very, very strongly, which means that more subtle assessments of risk are actually quite difficult because we're being driven by a risk-based model based purely on previous rating and time since last inspection. And I think as we explore moving towards intelligence-driven, we have to some extent move beyond that so we can be more agile in addressing risk that we see through our monitoring rather than relying purely on our previous inspection ratings. I think that's going to be a challenge for all of us.
Lewis.
Just briefly, first of all, can I say thanks very much, David. That's probably the best answer to my relentless questions about these ratings. And you didn't even have advanced warning of the question. But it will be important to get that information. And it sounds like you're committing to giving us that maybe from now. Because there are still some questions about it. I'm not going to list them all now. People's endurance is probably, we've reached the limit for the data talk. But there are some questions about why the figures are much higher for good and the few outstanding. We used to say that was because there's an alert about them and therefore we were going out to see them. But that can't be true of 4,500 locations. We must actually have a slight imbalance in how we're pursuing based on previous rating. And then the second thing is this other group who are not in the previous rating group, the people I mentioned earlier, this new group. There's about 2,500 of them by my calculation. We must have had have a relatively low figure on hitting the KPI for that group. Now, I don't say that critically because I know they've been looking at this task of reinspection, but thinking about it from a public point of view, knowing that there's a new care home which has been registered but not yet inspected, that's an understandable situation, but not one that can go on for too long. And I think that becomes a next challenge. But it's a hugely important issue because of the changeability of the ratings in social care, I would say, and because of the need to pick up on the new and the inadequates. And if we could have the kind of data that you've been outlining there in future as a routine, that would be really helpful.
Yeah, can I just come back on the new registrations? So the new registrations going forward from the 1st of April, you've got your new build registrations where people are entirely new to the market, and then you've got your new registrations where it's an existing provider that's coming into the and is purchasing that particular service. So going forward from the 1st of April, those providers whereby they may change from a limited from a Mr. and Mrs. to a limited company, or another provider who's already registered with us is purchasing a care home, that those ratings will continue. So we won't be starting from a blanket approach again. It'll be the new registrations, new people coming into the market, where we will be more assured that we'll be reporting on those within 12 months of the date of the registration, and obviously sooner if information of concern alerts us to things that might be going wrong and we need to get out there.
Great. Liz.
Thanks. I just wondered, Chair, if I could ask a question about Mendip House, a facility now closed that was run by the National Autistic Society, where I'm sure those of us that saw it were extremely concerned by the reports of real abuse of people in a very vulnerable situation. I know that I understand we took action to close that facility and took some other action as well. But I know there was some concern externally about, were the consequences of such abuse serious enough, given the seriousness of what went on. And I just wondered if it would be possible for us all to understand what happened and how we communicated it, whether there's anything else that we can do to reassure the public and to let providers know that that this sort of abuse is absolutely unacceptable and will not be tolerated within the kind of regulatory regime.
So Chris might help from the comms point of view. I think it's important to say that the people who lived in at Mendip House were really badly failed by those who were looking after them. So what happened, Liz, is that in May 2016 we received some information of concern, and this follows on from the conversation we've just been having. We looked at the information of concern from whistleblowers and we inspected straight away. Through that inspection, we found that there were serious concerns and a number of abusive practices that we highlighted as part of the inspection report when we rated it inadequate. A decision at the time was also taken to take enforcement action, the strongest enforcement action possible, which was a notice of proposal to remove the location from the National Autistic Society's portfolio. The National Autistic Society decided to close the service, so the impact of our proposed enforcement action had the right outcome for those people, and those people were moved to other supported environments so to ensure that they received the right quality care. We also investigated whether we could prosecute the National Autistic Society for failing to keep people safe, but we were not able to do so because of insufficient evidence. And that was the same with the police. The police were also unable to carry a prosecution because of insufficient evidence, which meant that any information that we would have normally shared, we couldn't because it wasn't there to be shared at the end of the day. But we did have evidence whereby abusive practice had taken place in relation to financial abuse, and we did pursue that, and we were successful in a fixed penalty notice of £4,000. Now, the way that we communicated, obviously, the information, in 2016-17, we were very open at that particular time of the action that we'd had taken, and I think it was the decision to, when we published the fact that we'd issued the fixed penalty notice, that meant that we had some more interest in the story. So, Chris, I don't know whether you want to...
I think there's two things that are clear in this, and I think it's important to reiterate that the most important thing to do was to make sure people were protected by closing the home. And the action that we took, as Debbie said, led to the closure of the home. The evidence that we need to gather in order to take criminal prosecutions, the police's investigation clearly took precedent over ours. And I think the speed at which the organisation was closed in part meant the information, the work that the police do to gather the information that would lead to a prosecution didn't take place. From our perspective, it was important that we then use the other evidence that we do have to take the prosecutions that we can do. We've since spoken to both people in the media and elsewhere who've raised concerns about this. But I think the really important point in this is that the action we took meant that people were protected quickly and that the organisation was closed. And then the rest of the action we took, we used all the available evidence to take the prosecutions that we could. And in the case it was a financial prosecution because that's the evidence that we had available. And I think that's the important part to bear. We've been back in touch with Barbara Keeley. We've also been in touch with the colleagues in The Guardian who wrote the initial story, and they understand that. And I think it's in some cases about reminding people, as we did on social media, this was actually about closing a home that was unsafe, and the criminal prosecutions would have taken months anyway, and it was more important to us to make sure people were protected.
It might also just be worth adding that the fixed penalty notice, the £4,000, that I am right in saying was the maximum that we were able under the law that we could impose for what it was we were able to prosecute on. And I would just also add, I mean, I look back over all the actions that we'd taken at the time, and sometimes when you do that, you think, well, with hindsight, I wish we'd done that, or we could have done something different. And in this particular case, I think we did all the right things, and it's not one of those cases when I look back and think, oh, well, could have been better. So I think this is about explaining rather than learning ourselves from what happened.
Thank you, that's very helpful.
Robert, are you coming on the same point? Because John was ahead of you, unless it was on that particular point. Right, John and then Robert.
Thank you. I met with Debbie recently to understand about the improvement in the ASC figures. And what I came across was a holistic, comprehensive quality improvement program that had been led by Debbie, started last January. And they commenced with 2 days end-to-end process, classic lean style, distilling out of that 4 key high geared areas for activity, leads for those. rapid cycle QI improvement stuff, often with weekly iterations, that the team as a whole, leaders as a whole, met together to ensure the whole thing added up, that there wasn't a rag rating in sight, but there was rigor around the data and the monitoring, because that initial thing had people from all geographies, you were building in your spread strategy right from the beginning and the outset. It involved people from finance, people and digital, so you were getting that cross-sector input. The results were demonstrating a median in report writing come down to 27 days. The factual accuracy dropped mainly now around 2 days, I understand. There was co-production of some of the elements such that the input from users around their home care is now much stronger. The quality of the reports was higher, recognised by dip sampling. And they didn't stop there, they rolled it out, WebExes, using these people in all the geographies to get it there, and have built on that structure to introduce OneNote across the whole thing in 4 months. This is truly impressive stuff, Debbie. And, you know, there was clear purpose, clear methods, single governing team, colleague ownership, things done with people, not to them, and 80% of transformation is involving people, not the method. I can say no more than I could not have designed and delivered it better myself, so well done.
And there is no higher praise than that John couldn't have done it better. So fantastic. Robert.
Well, rather more mundane, I'm afraid, but thank you. Going back really to Lewis's point, but we talk a lot, and quite rightly, about the timeliness of reports and inspections being important to look at the higher risk cases. I do understand that. But when we consider that, when we look at what happens to the people who rated requires for improvement, most of them just become good. If they are inspected late, the public and indeed the provider is being deprived of knowledge, of the knowledge that actually they're good, not requires improvement, when they've actually made that transition. Now, I appreciate that's the opposite of risk, it's sort of good news, but actually in terms of the public who rely on our ratings in relation to choice, it is important that the information that's provided to them is up to date. And so I would like that part of the risk, as it were, not to be forgotten.
That's absolutely key and critical, because people who use services or people who are choosing services for their loved ones, you're absolutely right, they need to have an accurate rating, and we have a plan in place. I am more assured than I was 3 months ago, and we're monitoring it extremely closely.
Anything else on the performance report? Kirsty, could I just it may not be for now, but the slide on the rejection rates for applications, so registration, that's all fine. But we're given the top 5 provider application rejection reasons, and they're so high level that they're really meaningless as far as I'm concerned, to provide a section or location section. So my question is, what if anything are we doing to make sure that providers can learn from where all the mistakes that have been made by people who applied before? And if you don't know now, can we?
So I think this is where we're doing some work around our quality improvement. So I think we've done some analysis on why we have these problems. We have a very complex registration process. The application forms aren't great, and the guidance around it isn't so good as well. So we're looking at all of that, and we're also looking at our process as well, in terms of how we can lean that out and make that much simpler to enable people to get it right first time. Because that's what we want, because it saves money all round for everyone. So what we're doing is we're taking a number of applications and we're putting them into effectively what we're calling a sandbox, where we're testing out how we can lean out this process and make it easier for people to work with us and for our internal process to speed that process up. We're testing that out we're doing it for the add and remove partner one and also the council registered manager one, which will enable us to test out the process, lean it out and on live applications and make sure it's working, and then we can scale that into live, which we're planning on doing over the next month or so. So I think we recognise that. I think part of the registration transformation programme is aimed at driving this forward as well. So our minimum viable product that we're looking at now is new provider applications in a social care setting, by trying to drive by driving that forward in a much more in a much simpler, user-driven experience type way, we should be able to make that service as pain-free as possible so that people do get it right first time.
That's very helpful, thank you. Anything else? Or should we move on? Perfect, we'll move on. And Kirsty, I'm sorry, it's back with you.
Thank you. So I'm just going to give you our quarterly change update today. There's quite a lot of data information in the paper, so I'll just pull forward a few key areas. So I think that the headline around our change and improvement portfolio for this year, so we've got 37 projects on the portfolio. I think we're seeing a generally improving picture across that portfolio in terms of delivery and managing the risks around that. We're also doing quite a lot of work around our quality improvement. We are in the process of recruiting a partner to work with us to upskill the organisation and provide support to a number of projects. We're hoping to have that partner finalised through the procurement process and in and working with us during April. Of those QI initiatives, we are doing some work in registration, which I just alluded to. We're doing some work around report timeliness, working with the business to support the improvement, and that can be seen both in terms of the improvement in report timeliness in hospitals and as the work that Debbie was also talking about. And we're also starting to look at how we can drive a more consistent approach across the organisation, and also look at when the partner comes in, how we can upskill our capacity and capability in this really important area. One of the areas that we've been really focusing on over the last 12 months is improving our user experience and really starting to address some of the sort of technical debt that we have in our IT services, and also some of the issues that we have around just how people are using our internal staff are experiencing using their IT systems. I think we've started to roll out improved kit, so we've completed the rollout now of the new laptops. We're starting to roll out smartphones across the organisation as well, and we've done quite a lot of work to improve the stability of our systems. And I've just seen some statistics that are showing that the downtime through unstable platforms has improved now by about 50%. So we are actually starting to be able to work more effectively through our systems because it's better. We're also working around our underpinning architecture, so this is the sort of the nuts and bolts, the wiring, if you want, that supports our operation day to day. We've got some work. We're currently scoping out the improvement to our replacement of our customer relationship management system, our CRM system, and this is quite a big piece of work. It's the key system that we have that holds all our data. It touches every single point of the organisation. And we're starting to scope that out in terms of what it needs to be both from a digital solution, but actually also from a business process, so that as we start to move the CRM, start to develop the replacement for that, we are business ready to take that on board. The other key area in this sort of area is our future IT services program, and this is the replacement of all from our existing contract, which is currently supplied by Atos. We've got a challenging programme of activity there where we're looking to swap out from one provider and create a range of providers under an integrated service there. We've now brought in the resources we need to start to manage that process, are currently in the business of putting together the business case to support that through to delivery.
Can I just on that, just ask, because it says in the paper that we need to do this by 2020.
That's correct.
Which end of 2020? Because sitting here in March 2019, that's quite a significant difference.
It is March 2020, so I think that is a really big ask. We need to recognise that there's a huge amount of work to do in a relatively short space of time there. what we're doing currently working with the programme is to just look at our contingency plans around how we might want to do a phased delivery if we can't get absolutely everything done and dusted by March 2020. But that's what we're working to, but recognise that it's quite a steep ask. Registration. Our registration programme is a multifaceted programme that includes service redesign through using service design techniques to really look at that end-to-end approach to how we are delivering our registration. It's also got an element of quality improvement in there and also an organisational design and people work strand. We've had a real success around our registration programme recently in that the piece of work we're doing under our service design team is has been in alpha. We have passed our GDS assessment to move that into private beta, and we passed it first time with flying colours, and that is a real achievement. And I think we need to recognise that the team there have done a really good job to take this really complex area and get that through this sort of big hoop the first time round. Around our intelligence-led approach to how we're becoming more intelligence-led, we have a programme called Monitor. We paused quite a bit of that work to really make sure that we were focusing on the right things. We've done a big piece of pre-discovery around that to really understand what are the key areas we want to look at in terms of Monitor going forwards, and what are the areas we want to focus in on. We've just about completed that on track, and we're now about to start to look at how we move that into a discovery phase and look at how we then look at that as part of the whole organisational operating model for the organisation moving forwards. On the people front, we are in the process of recruiting a new people director, so it is a little bit sort of holding the fort till they arrive. We've got a great long list of things for them to really start to focus in on. Key areas for us are around our workforce strategy, focusing clearly on skills that we need to now, but also for the organisation in the future, and our attraction and retention policy. So how do we get people into the organisation that have the skills that we need, and how do we make sure we keep them and keep them upskilled? We're also doing some work around our well-being. We recognise that well-being was an issue in recent staff surveys and ones in the future. So we're looking about equipping, giving people the skills to cope with working in a fast-paced modern environment at an individual level, but also we have a programme in place now to support teams to improve the overall well-being of the organisation. We're also doing some work to look at planning for next year. We are working to build a portfolio of programmes together which will support the delivery of our strategy. We're quite well advanced on that in that piece of work, looking at what we need to do. It's quite an ambitious, challenging programme, and we have some areas of deficit around resources that we need to look at how we bring in to manage that, and that is a key risk for us moving forwards, and one that we will be paying close attention to over the coming months. Thank you.
Thank you. Thank you. Questions, comments? Mark.
Thank you, Chairman. Kirsty, I thought in the report on people that the development of reconnection events for new starters in first 12 months was a really great initiative, especially when we look at our performance report where leavers for avoidable reasons is actually increased in the last month. So I just think that the ability to take that piece of work and try to show the evidence of that impacting on our turnover rates would be, a really, really good story for our people.
Yes, I agree, and I think particularly in the way in which we work as an organisation, we're a dispersed organisation. 60% of our staff are home-based, so particularly as we get new people in, it's really important that we make sure that they feel connected and supported across not just when they start, but actually over the first 12 months and onwards throughout the throughout their life, their working life in the organisation. So I totally agree. It'd be really good to look at how we can track that, and we probably need to build that into some of our people metrics moving forwards.
Right. Gosh, I thought it was a brilliant report. It takes my breath away looking at how much is going on. That's great. So thank you very much indeed. So that moves us on then to the business plan and budget, and this is a sort of update, Ian, progress report.
It is. Really, what I'm looking for today is just to ask the board to note the progress that we've made on the business plan. I think we've got a little bit more work to do, as we allude to in the paper, around presentation, but also there's a meeting of the board subcommittee that sponsor the transformation programme this afternoon as well, and again it's important we hear their voices properly in the business plan as well. So my request today really is just to note progress with a view to bringing the plan back to the next meeting.
Okay, does anybody want to ask anything, or are we just happy to note it and move swiftly on? My goodness me, we're making great progress, so thank you very much for that. So, Malta, equality objectives.
Thank you very much, Peter. I'm very pleased to present you with the equality objectives that we're proposing for the next 2 years. The equality objectives for CQC is something that we've been doing for many years now, and it's very important work. It's not just part of our obligation under the Equalities Act to be clear about what our objectives are around equality and diversity, but it's also something that guides and frames our work as a regulator, both for the services that we regulate and people using services, as well as for our own staff. The objectives that we're proposing for the next 2 years, so 2019 to 21, are very much based on and continuing the work we've been doing over the last 2 years, which have laid good foundations. But there's more that we can do. Central to this is that while these objectives are clear in terms of the priorities that they set for our work, they are not intended to be separate work. They are all about how within our wider approach, whether it's registration, whether it's the inspection and monitoring of services, whether it's our independent voice or how we work, our own colleagues and staff, that we make sure we pay attention properly to the equality issues that we've set out in these objectives and that we want to focus on over the next 2 years. Liz, you've been involved in this work quite significantly, for which I'm very grateful with colleagues. Is there anything you want to add?
Yes, I think that I think there's been some really interesting work going on across the organisation. A couple of things I'd point to. One is that on the one hand, we have that we signed off recommendations from the Roger Klein's report at the board earlier this year. Obviously focusing very specifically internally on colleagues from black and minority ethnic communities and the recruitment process in relation to race equality. We've also got the workplace race equality standard already in place, and the workplace disability equality standard going live in April right across the NHS and for ourselves. But at the same time as focusing on those kind of specific issues, I think there's a strong emphasis here on working across difference and recognising the intersection of a lot of the different equalities issues and working intersectionally, to coin the jargon. And I think keeping that balance right is important, and it seems to me that we are doing that. We don't want to lose, where we've got real evidence, for example, that there are disparities on rate equality, we mustn't lose focus on that. But at the same time, this is actually something in the internal space that will make working within CQC better for all. And similarly, in our regulatory work, where equality and diversity are properly attended to, you get better services, basically. So it's core, as you were saying. The one thing I would say is I think, and Kirsty and I have had some discussions about this, and other people have, I think we've still probably got a bit more work to do going forward on how we measure progress on some of this, and it's not straightforward. In the business plan, as it's currently drafted, obviously there's more work going on, there's like a placeholder for what the kind of top line, what are the most important things that would make us feel confident that we're making progress. So getting that kind of basket of measures right and the headlines right, I think we still need to do, there's still a bit more work needed, but with that proviso, personally I'm very supportive of this work.
Ian, did you want to add anything?
I'd just like to say that the way things are set up within the organisation is that it is, promoting ethnicity and diversity for people who use services, and also within the organisation. I think it's a great stage that we're at the moment.
Good. So still some more work to do, but great great progress. Sorry, Lewis.
Thank you. Well, I think it's a very important piece of work and generally pretty good. I did wonder about the urgency in the objectives. So there are two things about the outcomes that are described. One, I think, Liz, you've already referred to, which is some of them don't look very measurable, and so it's a little bit odd to have outcomes that you can't then say for certain whether you've met them or not. So I think you're right to think more about that. But I did also wonder about the urgency of them, that quite a lot of the first year outcomes were about people being more aware, and then the second year outcomes seem to be about people paying attention, and then the third year outcomes in general are about actual changes, and that seemed to me to be quite a slow pace, and I wasn't sure why awareness and attention take 2 years when they might take just couple of days, so I wasn't sure what that was about. So I would just ask you whether you could, either I'm missing something about the scale of the task, that we're starting at such a low point that we need a long lead-in time. I suspect that isn't totally true, but or we could just speed it up a bit. So I would like us to have achieved more in the next year than what most of the outcomes are about, which is this issue of awareness. There's an exception, which is the RES, actually, which is much more definite. There's one of the objectives about the workforce race equality standard, and it's much more definite and much more specific. And maybe that's because it's already in the system, and so it's a bit easier to be clear about it. And maybe progress has already been made on it. But could I ask is it possible? Is it too late to have a look at what the implied urgency about the outcomes?
Yeah. So on the urgency, I think this is partly a recognition that what we're trying to contribute here is a significant culture change in health and social care services. So even where there are clear mandated standards or expectations set through the Equality Act, for example, or the Accessible Information Standards, for example, the contribution we want to make is that where we can, we talk about this, we look at it as part of our inspection, and we change that culture over time. That means, I believe, that we're not going to see a change where everyone will do this in the way that we would like to see it within 12 months' time. And there will not be awareness in 2 days' time, because we know from all experience of this over the last decades that it takes much longer to achieve that. So I think it's a recognition of the role that we play and the contribution we make to it, because this is not just about CQC, this is about our contribution that we make. And the others playing in this are providers and their leadership and their staff, commissioners, other national bodies, the public and their voice around this, the Equality Commission, and so on and so on. So I'm quite happy to look at some of the pace of this, but I'd be cautious to say that CQC can achieve some of the outcomes that we're looking for, which is for health and care services to act in this way, could be something that we could say we can achieve and mandate within 12 months' time. Because don't forget, what we're not doing here is to set ourselves up to go around every single service to check for course standards and expectations. We're trying to build this into our ongoing approach to make this a sort of a significant cultural driver, rather than something where we are acting as the policeman of these issues.
Just to briefly come back, I just would ask you just to have a closer look at the wording of them, because of course it's not just our responsibility, but to give you an example, the outcomes we expect, this is, let me just check, equal access to care and equality of outcomes, actually. So in the short term, leaders in providers and ICSs are aware that CQC will consider their role in tackling inequalities. Now, how long does it take for the leaders to become aware that our job, so we're not asking for a major change, we're asking for people to be aware that we're taking this seriously. Providers will have greater awareness of their role. I mean, that shouldn't take a year to get to the point. Anyway, so I just, your answer, Walter, sounded slightly hesitant about whether this was possible or even within our remit. And I think it is, and I would ask you to look more closely at it.
Paul?
And whatever we do in that first year needs to be in our business plan. So that, in fact, the equality objectives are securely in the business plan.
Okay. Sorry, Robert, yes.
I wonder whether one of the problems with just listening to that conversation is that these objectives, which are obviously intended to be common expectations in regard to what people we regulate do and what we do internally, But I just, in the ordering of this, just in relation to each objective, there is a little bit of potential for confusion as to what we're expecting other people to do and what we are going to do, and because they, our internal expectations are sort of one thing we have completely under our control. What we expect other people to do is sort of it is not different in terms of what, the values and so on behind it, but actually in terms of the mechanics it is. And I just wonder whether the ordering of it could be just a little clearer. What's about the external environment and what's about us? So how are we going to influence the outside and how we're going to influence ourselves? But it's really good stuff.
So it's interesting, isn't it? Because when I was reading this, I was and I actually made a note that I thought the sort of 3-year program was really good, and I was sort of putting ticks all over it, Lewis. So, but listening to you, it's what the benefit of board discussion. You get this. What I'd like to suggest is that we approve the objectives, but which is what we're asked to do. But at the same time, Malta, we do look as really two things, that both of which Lewis has mentioned, where we can get more measurable outcomes. Let's move in that direction. And if you think there are areas where we can move with more pace and we exceed the objectives, that's a good thing to have done. Yeah, but with that, are we happy to approve the objective? The objectives are set. Good, thank you. Right. Imelda, well done for getting here early, since I thought we were going to be late, and clearly the communications are working well. Thank you, Naomi. So that's good. But Robert, do you want to kick this off?
Thank you, Peter. Well, I think everyone's had an opportunity to read what turned out to be quite a long report, but I think that somewhat reflects the range of activity that Health Watch nationally and locally actually does and the impact that it can make. I don't want to steal Imelda's thunder, but underlying all this, as you can imagine, is a huge amount of work, both by the office here and volunteers largely, but also a small and brave army of paid staff around the country are doing tremendous work. And I think that's evidenced by just two things I can pick out, really. One is the involvement we've had nationally in the long-term plan, not only in informing its development, but also now having been commissioned to oversee a consultation in every health watch in the country in relation to the implementation of the plan. And I think that's probably the first time that the people of this country have been given that sort of opportunity to be involved in what is, after all, their service, not the Department of Health service. But the work they do, which sometimes gets criticised, I think, because it's not statistically valid in the sense that something from the Office of National Statistics is, but it is, in my view, extremely valid. Firstly, a very large number of people contribute to this work. We've got over 85,000 voices, as it were, into informing the national plan. 400,000 people as views one way or the other have been received in the last year. And it brings up things in a slightly different light through, I think, the stories that people tell, and you've seen some of them in this report. And I think it's the impact of that which you can add to other forms of information, which can truly help to transform the way in which services are delivered. And I'd just like to pay tribute to everyone who contributes to that and hand over to Imelda.
Thank you very much. Well, as Robert said, you have the report here. I think the work on the NHS 10-year plan has been a bit of a game changer for Health Watch, I would say, both in terms of, I feel that our reporting on the insight from the public has really improved to a standard that we can, with confidence now, share that at large scale and also very specifically. So within that 85,000, there were 750 street homeless people's experience of using GPs or A&E departments. So it's both global and specific, and so I feel like we're in the best position we've ever been able to really get that insight properly into the system. And I think NHS England and other organisations, National Audit Office, many others, are really getting to understand the value of that insight. and understanding its role in shaping future services. So on that scale, I think we've come a long way recently to really be able to deliver that. We are, as Robert said, we are in the process of running engagement events in every part of the country right now. The team have just been fantastic. It's a small team, and they have pulled together guidance on every subject matter you could imagine to help run any event anybody could imagine in any part of the country. Of our 152 local Health Watch, 150 will be taking part in running events, and 44 of those have come forward as leads for their area, so they're working very directly with the STP, so that we're completely relevant to the local systems and structures that are making the plans for the future. I think that piece of work is actually going to be quite a game changer for how Health Watch is understood. There are also within here other things I think we've made great progress on in the last quarter. I just want to draw your attention to the reports library that we've now launched that's on our website. We have around 2,000 reports on there at the moment. We will have the whole backlog back to the day we were set up on our reports library by early summer, May, June. So probably around 5,000 or 6,000 reports on insight right across the country on a whole range of things. So you could go on there and you could search for example, Gypsy and Travellers' experience of primary care, and up will come the reports that have happened across the country in that subject matter. I think, again, that's being very well used. We trialled it with a number of organisations, including CQC, National Audit Office, Sky, a whole range of people. So we got some really great feedback, and it's proving to be very, very popular. Policy work goes very well. In here we talk about the work that we did on hospital readmissions. We had noticed a spike in readmissions. We noticed that that this was not being analysed, or the data was being collected by NHS Digital but not being analysed. They have now agreed to start analysing it. And there's those sorts of examples are happening quite frequently now. A lot of work that we did on oral healthcare in care homes along with CQC, that now has become mainstream. So I think we can really see the impact of people telling us things and then getting a response that is sustainable. I think one of the other big changes we've had in the last quarter has been the quality that has come from being able to have secondments in from the network to help us really move forward on things like making a difference toolkit, impact toolkit, on setting research standards. So that real sense of it being one Health Watch and us working together has really come a long way. The other thing that's made a massive difference is our ability to give grant in aid to local Health Watch to carry out pieces of work that we want done across the country, but we can't mandate local Health Watch to do things, but being able to give small amounts of money frees up their capacity to help us. So an example of that is the work that we're doing on maternal mental health and on young people and mental health services as well. The only final thing I want to say is I apologise for the length of the report, and I had flu last week, and I can see that what would have been better is to divide it into two. So one, you get the sort of an insight report which is less repetitive, and one is what's going on in Health Watch. And if that's useful to you, I'll do that for the future meetings.
So I was going to say, Imelda, that given the brevity of the report, I assume this is just a few of the highlights that the real...
Sorry.
It's a fabulous...
Foggy brain.
It's fabulous. I love it. Thank you very much. John.
Imelda, can I just endorse that? I really enjoyed reading this.
Did you?
And it gave me a much clearer picture than I had before. And I'm just stunned by the breadth of stuff that you guys do. Mm-hmm. And the link between getting a report and getting sustainable policy and action result is just truly commendable. So thank you for sharing it, and may the force be with you.
Thank you.
Lewis, we haven't heard from you for a while.
Thank you very much. Thank you. No, indeed. Well, I thought it was a really good report. So I didn't find it too long.
You didn't? Okay.
And I mean, what was good about it was the breadth of personal stories. So they were quite diverse in lots of ways, and but a couple stood out for me. There were the experiences of homeless people with mental health problems, and the experience of people trying to get their medication from their local pharmacy. And it was quite an interesting reminder of how people's experience of care, no matter how good our staff are in a professional sense, and whether policy intentions are enacted and nice guidance followed, a lot of people's experience of healthcare is actually about the day-to-day things that go wrong. So going to the pharmacy and discovering that nobody knows what their prescription ought to be, and then they miss out, can't get their medication and run out, and those sort of things. And so they were really quite very recognisable and quite, I imagine, very common and quite powerful stories about people's care being adversely affected by, in one sense, quite small things going wrong. So I did wonder where this goes, since it's not about policy and it's not about nice guidance and it's not about it's not really about CQC inspections or any of those things in a way. I mean, it could be, I suppose. But about where it goes. So where, for example, if we take the prescription problems, which, as I say, is a day-to-day problem, but actually potentially very serious for some people. Where does that the report? Where does this go now, and who takes responsibility for responding to it?
That's a really good question, and something that I think I still think we're not having maximum impact from knowing this stuff. So it happens on a number of different levels. So at a local level, they will report that into their CCG, and they will say this is what's happening in our local area. At a national level, I think the issue about medication is quite interesting because that's come up as a higher issue than it has been before. And so what we will do is make sure that we have the meeting with the appropriate people within the Department of Health and Social Care, and we tell them about the trends that we're seeing. So that's if you like, that's the real challenge for us is now to get people to listen and make changes as a result. So at each of these points, we have exactly that conversation and put a plan in place about who do we need to let know about this change. So yeah, I think it needs to be tighter, to be honest. But to be fair, we're just getting the stuff through now. So now,
I think if I could add to that, local health watch, and they have a varying approach to this, but they are a very valuable collecting point for local knowledge about general practitioners who perhaps aren't as good as some other places in doing things, or a particular pinch point in the hospital service. And they do, in the good ones, they will have immediate access, or on a regular basis, because they have good relationships with CCGs and often with providers as well. And I think in a quiet local way, they can get things done. I think the challenge for us here is sort of the collation of the information in a way which has impact nationally. And obviously on some of these issues it's going to be easier to identify what that is than others. But I think one of the values of Health Watch is that because we're not a regulator, and that we're sort of the little brother of you lot, the big regulator, but we aren't a regulator, and that gives us a bit of freedom to exercise a bit of judgment about where things should go without actually having to go through hugely formal processes. And I think that's probably the place we should be in. But certainly there will be occasions when we should and do feed information friendly formally to CQC or possibly to the GMC or other regulators. And I've been in discussions personally with at least one professional regulator about how we can enhance that process.
So Mark and then Ted.
Well, can I echo that I thought the report was really interesting. I enjoyed reading it. It made me think that at the Steve Fields sort of going away lecture event, we had a presentation from a primary care organisation that had set up an outreach team to specifically support homeless in their community. And I wonder whether this sort of report with the content in it is perhaps something that can be used to encourage that innovation to help those people most in need.
yes, I think it can. I think it needs to be written differently, and it needs to be more web friendly. But I think, yes, I think you're right. It can.
yeah, I guess it could be targeted towards CCGs or whatever to develop that sort of application of it. Thank you.
Ted.
Can I welcome the report as well, Imelda, and I enjoyed reading it, and I think the juxtaposition of patient stories with the highlighting the concerns is really a very helpful way of laying it out. So thank you for that. It was great. The couple of points for me. One is the emergency readmissions. Thank you for getting that reinstated. That is useful information which we can use. So I think that's really positive. So congratulations on that. Can I also highlight that the concerns that you raise, do have resonance with us from our inspections, and I hope that reflects the fact we're talking well with you locally. I mean, particularly the concerns about A&E, the concerns about mental health patients in A&E, which Lewis has referred to, and there's also issues around paediatrics in A&E, and those are both big features of our reporting on A&E over the last winter. And I think that there are important concerns that the system does need to address, and I think there's real opportunities for us to work together to make sure they are addressed.
Thank you. I completely agree. I think we're not yet maximising each other's knowledge and information, and Chris and I meet regularly with our teams, and I think we've a long way to go to sort of, and the word I've always used is hardwire it into the way that both we work and CQC work. At the moment it's still reliant on good relationships rather than a must-do automatic way of working. So I think we'll keep plugging away at it.
I think that's a good point. I think there's two parts to this. We had a presentation this morning about how we develop an intelligence-driven approach, and I think the more we can automatically feed your information into that approach as we're developing it will be crucial. And I do think there's also opportunities. Medicines management is a good example of it, where we need to work out what our collective voice is and where we target and who we target to get the right change in behaviour locally and nationally. So I think there's more work to do in that space, but we'll pick up.
So Imelda, I think you'll have gathered from the board reaction that they think this is just about okay. And seriously, would you pass the board's congratulations to your team and also to everybody involved in the local health watches? I mean, I think this is really a super step up in what we're seeing, and therefore presumably the performance of everybody. So great. Thank you very much indeed, and thanks Robert as well. Right, board, is there any other business from the board for the board? Right, so that ends the meeting. Miraculously, having started late and said we were going to run late and there wouldn't be time for questions, we have got time for questions. So we're in good shape, and I'm going to take. We've got time for all the questions, but I will take them in the order in which they came to me with respect. So, David, I'm going to start with you, please. You're on the list.
Thank you very much, Chair. David Hogarth, Neighbour Care, St John's Wood and Maida Vale. I recently looked at Care Home Professional, the latest issue. There was an article about Wi-Fi in care homes, and it said that there have been two reports recently, both of which said that Wi-Fi, the existence of Wi-Fi in care homes was extremely important to prospective users, of prospective residents, more important, not surprisingly perhaps, than spas and that kind of thing, even more important than gardens. And yet only 1 in 5 care homes actually have any Wi-Fi in it. I wonder what the CQC was doing to encourage the spread of Wi-Fi.
Thanks, David. Debbie?
I can't quite see there, David. It's a really good question, so thank you for raising, and I think you'll be aware that we are actually committed for our strategy with the role that technology and innovation can play. We also acknowledge that access to Wi-Fi is a commonplace for most people. And why shouldn't it be for people moving into or living in care homes? In fact, it's often considered as an extra utility alongside water and power. And I think we know that the importance that it can play in person-centred care and enabling people to lead a good quality of life with the use of technology. However, we haven't got the legal powers to require care homes to provide internet access, but we do through our assessment framework, and in particular the key question on responsive, ask the questions that you've just asked, David, and we will report on them on our inspection report in our inspection reports, even more so going forward, because we're actually seeing some of that innovation now and the benefits that Wi-Fi can have in care homes. So thank you for raising, and to help encourage the improvement as well and drive it forward, we've actually launched a web source resource in November 2018, and on our external page we have got some examples of how the benefits of internet access and is encouraging people to lead a better independent life. So thank you.
Good. So, Robin, I think you're the next question, basking in the praise for Healthwatch, no doubt.
Thank you, Chairman. Robin Pike, patient representative, Healthwatch Hertfordshire. I'd like to ask how the key lines of inquiry are applied when inspecting secure psychiatric units, and particularly those that treat adolescents.
Thank you. Ted?
We apply them in exactly the same way we apply them everywhere else. I mean, our framework is consistent regardless of the service we're inspecting. So I'll answer any specific issues you have around it, but the key lines of inquiry are used in exactly the same way. For each specialist service, we will have some prompts to help the inspector understand the evidence behind each key line of inquiry, but the key line of inquiry stays exactly the same.
Does that answer your question?
Well, Chairman, there have been some issues in these units, particularly where adolescents have been kept in the unit well beyond the recommended period of time.
Indeed, and that is the subject of a thematic review, which we're undertaking at the moment, that will produce an interim report in May, which I think is going to be very important. I don't want to preempt what we're going to say there, and then a substantive report early in 2020. So I think we are looking at that because I think others have raised concerns about it, and certainly in some of our inspections we've found concerns about individuals, and we're now looking at it on a national basis as part of a thematic review. So I think we'll have something very clear to say about that shortly, and I hope we'll be able to make a difference to some of the problems we've found.
Good. Thank you. Thanks, Robin. Mr. Russell.
Hello, I'm Martin Russell, member of the public with an interest in patient safety. Just to put my question in context, context being the Learning from Deaths review programme. I know that just this week there's been a report by the CQC to update the progress, and the outcome of that, my understanding, is that it is culture change and leadership that is absolutely key. Learning from deaths, not the most pleasant of subjects, but I'm just having attended the board meeting, I'm hearing that culture change is, and well led, is an emphasis throughout the whole of the CQC with its regulation, combined with the use of movement to business intelligence, as one would expect. Not necessarily artificial intelligence, but business intelligence. So what my question is, and having read the report of the progress of learning from deaths, which is talking about it being a qualitative issue as opposed to a quantitative issue, culture change, leadership, is there any work going on within the CQC that is qualitative? How do you measure from intelligence whether trusts, or I'm talking about in particular case maybe focused to acute trusts, whether is there any work going on to actually measure quantitative measurement of the culture within trusts? springboard for the question is I read, for example, in the news, it was across all of the national newspapers, despite the current negotiations, about the culture of bullying in the NHS, where there was quantitative work by Freedom of Information rating trusts, the 70 trusts, by the number of formal complaints that staff have made about bullying and harassment. So that might be one avenue of quantitative work. And also the other thing I was interested in, well, just to touch on that, at a previous board meeting there was a lot of discussion about whistleblowing. Whistleblowing is a very, very complex subject. It doesn't do it it's perhaps wrong to refer to it as business intelligence, but I know that you get about 8,000 reports of concerns raised per annum. Are those concerns broken down as intelligence, for example, by ward, so that that information can be used to build up a picture? So the real question is there going to be any work going on to analyse well-led culture? It's a very difficult way, but how do you do that, and will the CQC be doing that?
That's an easy question for you, Ted.
Well, I'd like to start off by thanking Mr. Russell, because you provided us with very useful intelligence about your own case or your mother's case, and I think it's really been helpful to us in terms of our inspection and regulation.
Thank you. Yes, I didn't want to touch on that publicly.
So gratitude to you, and I think you raised some really very interesting questions. I'm not sure I can answer it all. Culture is something. There are measurements that we use. I would not argue that we can measure it precisely across the board, but we use particularly the staff survey, and there's been a recent staff survey published for the whole of the NHS, and we have identified that some elements of the staff survey are strong predictors of the quality of care that patients experience. So staff's experience of working in an organisation is really very important in terms of their ability to provide high quality care, and that's around issues such as engagement, but also issues such as race equality standards, where we find that those trusts who score poorly on race equality are often the trusts that have the culture that delivers poor quality care as well. So there's a kind of sense of, if you look at staff's experience working in an organisation, that can predict quality. And I think that's an important insight that's come out of our inspections, and it drives a lot of our work around well-led. So in terms of well-led, I mean, clearly we spend a lot of time talking to staff and talking, so hearing their stories, not just about looking at data, but the data very much informs that, and some of the data I've looked at very much informs the well-led. If I can come back to the whistleblowing, every whistleblowing story that comes to us is looked at by the inspectors who are looking after or regulating that organisation. Sometimes it will lead to us asking questions, sometimes it will lead to us taking action such as doing an inspection, a focused inspection. And sometimes it will inform our inspections, and some of our inspections are heavily driven by whistleblowing stories that tell us there are cultural problems in an organisation, and then we go and look for those problems and try and draw them out to reflect on the quality of care in that organisation. And of course the inspector, if it's about a specific ward, we will go and have a look at that ward. So to come back to your point, we drill down in, so if a member of staff says I'm unhappy with the safety of care on the ward I work, we will want to go and have a look at that ward as part of our inspection. So I'm not sure if that's answered the totality of the question.
Yeah, because what I'm just intrigued is, we talked about culture, but culture, I presume, is across a whole trust. But can you have pockets of good care and pockets of bad care within one particular trust? But then it's a complex, this is more of there's such an emphasis on, it's a complex area, an emphasis on culture, but there could be trusts, I'm presuming, that could have a poor culture, yet have good care in some parts of it.
Yeah, I can think of one trust I remember that came out very poorly, but had one service that was outstanding. And when you went to look at that outstanding service, essentially what the leadership did was to protect that service from the culture of the whole trust around it and secure that. So you can have macro cultures within a trust. It isn't a uniform culture. It depends on the size of the organisation. Sometimes multiple site organisations have different cultures on different sites. And that is generally reflected in the quality of care that patients receive in different parts of the organisation. And it's perfectly possible to have really poor care in one ward, and then just down the corridor, another ward providing very good care. And that is the local leadership. And it's leadership at all levels of an organisation that drives good quality care, not just in the boardroom, but also, you know, middle management and the clinical leadership at the front line that are really important in driving high quality care.
So thanks, Ted, and thank you very much, Mr. Russell. Thanks to others. And that, I think, is the end of the meeting. Just before we break, Kirsty, we're starting again this afternoon with something from you. Would you be ready to start in 3/4 of an hour?
Yeah, I'll just check how many's around, but
Yeah.
should be fine.
Otherwise, you're on your own. Yeah. Fine. So we'll aim to start at 20 to 2, unless Kirsty's got a white flag flying. Right. Thank you all very much indeed.